particularly Kim and Nicole. I'm really honored to be here. And I do agree with my fellow, sorry, your name was Ida? Ida, okay, I agree that I do believe actually midwifery care is a much better positioned to provide care for disabled people than the other forms of care. So I'm going to start with a little bit talking about myself, introduce myself, and I think in the introduction, Kim mentioned that I identify as queer, a person of color and an immigrant who self-identifies as disabled. I have a chronic health condition, as well as I identify as psychiatric system survivor and med identified, and most recently a parent to a 2.5-month-old. And I think it's important to mention these demographic factors because these are the factors that actually helped me or decide to choose why I particularly choose a midwifery care. So I want to start with actually before my experiences, discussing my experiences, to mention or highlight why I particularly chose a midwifery care. Beginning with the awareness of the medicalization of women's bodies in general and childbirth and pregnancy in particular, that I was quite aware, my background being in gender and women's studies, that I was aware and I did not want to, regardless of disability, regardless of former previous experiences with psychiatrization or hospitalization or like the healthcare experiences from the get-go, I knew that I didn't want I want less intervention because of that the highly medicalized nature of the childbirth in North American context particularly. Secondly, as a queer and trans couple, we did conceive our baby in an unconventional, untraditional ways. And while I'm very grateful to the new reproductive technologies, if you want to take advantage of them, they are also highly medicalized and clinical context they take place. We did actually use the services of a fertility clinic at Mount Sinai for a while, but our experiences indicated that that was not, I mean, we were lucky and privileged enough that we didn't need further intervention, but if we needed, it would have been a much stressful experience full of tension for us because of the nature of the reproductive technologies and the context they take place in a very clinical context. Thirdly, because of my experiences with long-term psychiatrization, psychiatric diagnosing and labeling, and interactions with the healthcare professionals, I do have, unfortunately, developed an overall mistrust of the healthcare system. So I knew, again, that I did not want, I want less medical intervention as possible if we could work with on our own. And finally, also being an immigrant and not having the access to OHIP, believe or not, also helps you sometimes to have an better or alternative ideas or alternative ways of accessing healthcare. And up until 2 years ago, I had no access to OHIP, and I've been in Canada for 19 years. So please calculate how long I did not have any access to OHIP or any provincially funded healthcare. And so I knew from get-go again that midwifery care also provides care. Midwifery provides care even if you don't have health care, if you don't have health insurance, so that you could have access to their services. So that was also an important consideration for me because we decided to have a baby. It was a long process as a queer couple. It took us 3 years. So 3 years ago, I had no access to OHIP, but I knew that I could still have a baby with the care of the midwife. So it was important to me. So given these factors, I was looking for a pregnancy, a practice that recognizes pregnancy and childbirth as a natural events and not medical conditions that require medical intervention unless there is some reason necessary that needs a medical intervention. It was also important to me to look for a practice that centers on informed consent, that gives clear, accessible, and detailed information about the process, any procedures, tests, exams, checkups that needs to be done, explains pros and cons, but most most importantly, if for any reason that I disagree to get any test done, and you may be available, you may be very familiar if you are disabled yourself that genetic testing is huge. I mean, not disabled, you don't have to be, if you have go through the pregnancy, you know, you are, for your own good, your benefits, you are encouraged, if not pushed, to do a number of genetic testing to be done. And so it was important to me that if I disagree to get any of this test done, which I did, that I will get support, not pushback from my caregivers, or that even if after they explain to me pros and cons and detailed information, if I disagree, that I would want them to respect my decision and not to create even more stress for me because of my decision. So this was another aspect that I was looking for. I knew this was a wrong stretch, but I was looking for a practice that would provide, or would have a med or psychiatric system survivor or psychiatric disability positive approach and understanding, which was not that easy. A practice that does not pathologize people with psychiatric diagnoses, regardless of the diagnoses or how long they've been in the system, how severe, quote unquote, that their condition could be considered, whether or not they are taking medications or not. Because I had issues, because in order to get pregnant, I actually withdrew from all my medications, and that was not well received in the fertility clinic. They were like, you could still take it, you know. I'm like, no, this is my decision and I don't want to. So it was important for me that the people would respect my decision about what I liked or how I would like to proceed with this journey. Also, it is very well known, if you have a psychiatric diagnosis, even though I was not told directly by my healthcare practitioners or specialists or psychiatrists, most of my friends were told that we should not have babies. This is actually very common, more common than you may think. And if we decide to have a baby, then we will consider it irresponsible, and that our activities, actions, behaviors will get much more scrutiny. We are told not to have babies, either because we are deemed will not be a good fit parent, or that legacies of eugenics movement that maybe we carry genes and that's irresponsible because we will make our kids like have the same psychiatric illness or disability disorder, and so that is very irresponsible. So that was important to find a practice for me who would support my decision regardless of what is my history, regardless of what is my diagnosis of label, regardless of like all these details, that will support and not pathologize me or not think of me as irresponsible, because this has happened a lot. And again, as you mentioned, a practice that's based on building and trusting relationship and collaborative decision making. Also, a practice that understands and is knowledgeable about and supports diverse family forms in terms of gender and sexuality and the ways of conception. And a practice that's based on reproductive justice framework, which intersects with both disability justice and racial justice. These were all really important factors for me. Coming to my experiences, all these things in mind, first of all, I like to state that I think I've been privileged and lucky to be in Ontario and to have access to midwifery care. I lived in Newfoundland before I moved to Ontario, and I do believe, as far as I am aware, that it's still not available to access the midwifery care in all parts of Canada, not in Newfoundland. So overall, I did have a positive experience. However, I'm also privileged to quote unquote, for the better of a lack term, pass or not to disclose disability. And this is actually what I chose to do. I did not identify, even though I identify very easily queer and trans to my midwives, I did not identify any part of disability and madness or psychiatric history. And I like to discuss with you why. And again, I like to say that this is unique to me and my experiences, so I can only speak to that perspective, and that I also have the privilege of not to disclose and still access the services. I did actually have a very minimal, again, I had a very minimal amount of disclosure, only passingly in the initial intake. And even though I thought I had serious concerns and worries, A, about the pregnancy, the emotional toll the pregnancy can take on a body or a person, like your whole being, and also B, postpartum depression. Postpartum depression was particularly something I was really worried about, but yet still I did not discuss. And I did not mention any worries or fears because this was due to not having any clear indication of whether or not my caregivers, my midwives, would be familiar with, knowledgeable about critical understanding of disability in general, or psychiatric system survivors, med people, or people with psychiatric disabilities in particular. For instance, about diagnosis, how to understand and make sense of like all these diagnoses, labels, not to know them, but how actually develop, understand a critical understanding of what does it mean to be labeled with a certain diagnosis, having a certain medication or not. Whether or not they would understand my fears or worries around trying to have a baby with a long psychiatric history, or even be comfortable with working someone like me who withdraw all his medication, all her medications, all, against medical advice and this and that, or someone with a long history of diagnoses. Whether or not they will be familiar with alternative supports or resources in any case of mental or psychological distress during pregnancy, childbirth, or postpartum period may bring about, other than the mainstream or conventional places, supports, or resources we see everywhere. I wasn't sure if my disclosure would lead to an extra scrutiny on my words, on my feelings, on my behaviors, on my choices, and over caution on their end. And I have to tell you here, I'm also over 40 years old, and my experiences with ageism in the system, also with midwives, unfortunately, indicated that this would have been the case if I did actually disclose. I think you either already mentioned this is partly due to the access or to eligibility for midwifery care is defined by normal and low risk pregnancy in a context where disability already is seen as out of the norm, and that disabled mad bodies are scrutinized for their level of risk. So if you are already operating with this framework, it is really hard to it is important to change that framework, because I knew it, because everywhere it is written as low risk and normal pregnancies, so it makes you to hesitate and think about before you have any disclosure. But I was also uncomfortable and uneasy when there was a constant referencing in my meetings to scientific research, quote unquote, and statistics, as I believe this was as part of the legitimized practice, their recommendations and care as regulated health professionals. Because if you look at the history of the midwifery care, you'll see that for a very long time, it was not considered, quote unquote, an actual healthcare profession. They were like marginalized, they were actually dysregulated. They were not access to, so I think it has a very recent history as a regulated health professionals. And I do feel that, so some of those anxieties or constant referral to research, scientific methods, medical community, came from, this is again my interpretation, to legitimize their practice as midwifery regulated healthcare professionals. But unfortunately, this made a really negative effect on me, because it made me to step back and think, okay, I'm not sure if this information was necessarily relevant or related to me, and this is particularly about giving birth over 40 years old. Some of the recommendations and the statistics were given to me were certainly at odds with my wishes and birth plan and desires, and I did feel pressured. I did feel pressured to follow up with some of these recommendations, which is because the scientific literature suggested. For instance, after 40 weeks, I was still not having feeling like I wasn't, I wasn't ready to give birth, like the baby was still there, taking his sweet time. And I did have a pressure to have induction because the literature suggested if you are after over 40 weeks old, your odds of having a stillbirth is increasing from 1% to 2%, and that I should have an induction. I was absolutely no, because I knew this was not because I also don't want to suggest that I was just being adventurous and I wanted to put at risk my baby's life. I was having regular ultrasounds twice a weekly, which I wasn't even sure it was necessary, but I didn't want to risk. So, okay, the ultrasound results are all good and fine. Everything seems okay. And so I wasn't sure why there was this push to induce the baby after 40 weeks, only because I am 49, I am 40 years, over 40 years, but not 39. So that was actually one of the reasons that made me think, if this is happening with just being over 40, what would have happened if I disclose all sorts of diagnoses or long history with hospitalizations and psychiatric stuff? So I was kind of happy that I didn't. And again, if I can suggest the midwives in this room one thing, when you do notations on your files, on your clients' files, please explain what are they. Because again, I've seen everywhere on my file these notations called AMA, and which apparently means advanced medical age. But when you Google AMA, the first thing that comes up actually in the medical terminology is against medical advice. And guess what? All my life as a psychiatrized person, all I heard was I was always against medical advice. And so all I could think the entire weekend when I discovered this notation on my file, because they give you your file after certain weeks, you carry it with you and you bring to each appointment towards the end of your pregnancy. Imagine if all your life you've been told being a problem patient, you are being against medical advice and this and that, and you see the same notation you think is on your file. That was an incredible amount of stress for me, and it created a rift between me and my midwife until we clarified that AMA actually meant advanced medical age. Even that was to me why it had to be. Anyways, that is a different discussion. But so I think these are really important to consider. And so, just to sum up briefly, this experience taught me to think about that if you are wondering or considering how to make more accessible, I think one of the things that's important in the midwifery care is to be intentional and explicit in communicating if any, you use any disability, med, deaf, positive framework or approach. It also made me wonder how much these topics are covered in the midwifery education. I don't know how much in the midwifery education there is a discussion or teaching around disability and critical understandings of psychiatry or mental health care or postpartum depression, or what does it mean, and alternative resources or critical frameworks. Again, the other thing I was thinking was representation. I was thinking it was easy for me to out myself as a queer trans couple because I had also midwives who were queer and person of color. So that was really easy and we really related. But there was no disabled. I was thinking, where are the disabled midwives, right? If I think it is important to see this is the framework that I operate or we operate in my work, that we try to represent, provide the representation of the people who provide care or who work with the people that we work with. So I work with queer and trans disabled individuals who are also racialized, and all our staff in our workplace is queer and trans, racialized and disabled, identified with. So it is really important because it kind of creates a level of relation that I built. It's easier, not necessarily and not essentially, but that it may create a more easy to relate to each other and our experiences. So I was wondering, where are the disabled midwives? And it was another question I had. And also, I do believe that midwifery care, again, better positioned to provide care because that you do come homes and provide home visits, which a primary healthcare person would not do. So, and I think it is important to be prepared. I would have had benefited it if I was out and if I was necessary accommodations, because there were times when it was really hard for me to leave bed toward the end for whatever reason, to go to an appointment, to make that appointment. And if there is a care that they could come and provide the care at home, that would have been much more beneficial or help me, or wouldn't need to necessarily reschedule or lose the appointments. And I think, lastly, I like to say that it is really, I think ageism really stuck with me in this process more than anything else. So I would really like to see and hope to see that how disability and ageism intersects in the care that you provide in the prenatal and postpartum during the whole care, because the most stress that I experienced in this process was due to being over 40 years old, only because I wasn't out in other ways. So that will be my words. Yeah, thank you.
Thanks. Well, first,